Good afternoon, everyone. It is my pleasure to introduce Dr. Keisha Callins. Dr. Keisha Renee Callins is a physician and public health professional. She is an obstetrician gynecologist with Community Healthcare Systems and is committed to providing healthcare services, especially in Central Georgia. Dr. Callins also serves as a professor in the Department of Community Medicine at Mercer University School of Medicine. She earned her Bachelor of Arts degree in biology from the University of Virginia, Master's in Public Health degree from the University of Alabama at Birmingham School of Public Health, Doctor of Medicine degree from Morehouse School of Medicine, and graduate medical training at Morehouse School of Medicine OB-GYN residency program, where she served as chief resident. She is actively involved in pipeline mentorship, translational research, legislative advocacy, and community engagement. Her personal mission statement is, "You may not be able to change the world, but you can change the world of everyone with whom you interact." Please help me in welcoming Dr. Keisha Callins.
Good afternoon, everyone. Ooh, we're going to try again. Good afternoon, everyone. So the really good thing about me speaking during lunch is the next speaker will have the sleepy room. I am very excited to be here today, and thank you for the opportunity to be able to speak again. I wanted to first of all start out by saying thank you to everyone that's present today. Everyone here is working to help our moms and babies in Georgia, and we have a lot of students in the room who are learning how to be good helpers as well. And so I just want to salute everyone in the work that you do, everything that is seen and unseen. I like to say that because there are a lot of things that we do that happen outside of the regular business hours. So I want to make a tribute to you for that. I like to start by setting the tone, and this is one of my all-time favorite quotes. For those of you who know me, I have lots of quotes. But I really like this one because I think it's important for how we focus the work that we do. And if our moms and babies are not doing well, it's not their fault. We've got to work on the things that in their environment that are going to be helping them. And so with that, we'll get started. So I do have a lot of slides, and my goal is not to read through all of them. I'm sure that you'll have access to this information after, so I just really want to go over the presentation, highlight a couple things. But my goal is that you'll spend some time reviewing the other presentations that were done today and as well as mine to help complement the work that you're already doing. And if nothing else, as mentioned before, make new friends before you leave today. Make sure that you know someone from Statesboro or Albany or Columbus or Dalton, but make sure that you leave with a new friend. I already have about 3 for today. So with that in mind, I love this quote, "Failing to plan is planning to fail." But what if you don't know what to plan for? And so I want to tell you a little story. A friend of mine, and I told her I was going to use her name today, Natasha Taylor. She's with Georgia Watch. That's a good group that's also doing a lot of work. They train community healthcare workers, and so if you have not looked at the work they're doing, just Google Georgia Watch and learn a little bit about them. But she texted me, this was February the 26th. I'm getting old, I can't read this. So she said, sorry for the late text, you can see what it says, and basically her sister-in-law is scheduled to have an induction of labor, and she's getting ready to go to she went to the hospital, and then she called before she went, they told her not to come. So of course, she's concerned, because she was told it's time for your induction of labor, and now they're telling her you can't go. So I'm starting with that because when those things happen, you want to start thinking about, the information that patients receive. Who do they talk to? How do they understand that? The person that told them they can't come because the hospital is too full. Well, what else should they be saying to help give them reassurance? Because they don't know what to do. They keep thinking, my baby is in danger, it's time for me to go in, and I can't go, so what's going to happen? So, hence the late evening text. And so I start with that because we really need to think about how we communicate with our patients and what it means to be a part of that community. So with that, I'm going to fast forward and I'm going to tell you that she introduced me to her brother and sister-in-law by text. And it's interesting because if you read the quotations, there's this article that I'm going to talk about in a second, and I had shared it with them. We had that earthquake in California earlier this year. I'm not sure if you all listened to the NPR segment about how all the mama elephants make a circle around the babies, and they literally stay there until the ground stops shaking. And that's the alert circle. And so that experience with them actually became the inspiration for this presentation. I remember trying to figure out what we're going to talk about, and Glenda and Joan and I were all working together, and I was like, I got it. But if you look at his quote to me, he said, "Thank you for being one of our elephants." Has anyone in here been called an elephant? That is not complimentary. However, when he read the article, this is a dad, that's the comment that he wrote back. "Thank you for being one of our elephants." And so I am sharing that with you because as we think about what animals can figure out to do, we also can do the same thing for our moms. When there's a crisis, we need to figure out how do we form that circle of care and how do we stay there, whether or not it's in the hospital setting, in the clinic setting, or in the community, to make sure we're helping our moms. And if you all have looked at the data, which I know you have, to look at the maternal deaths that happen throughout the year, the majority of them happen between 6 weeks and 365 days. They are not in our usual follow-up care immediate postpartum. They're at home, they're back at work, they're at the grocery store, they're at the football field with their kids. And so that means the community that we are is responsible for really keeping eyes on our moms. And a lot of that doesn't stop at the 6 weeks. Dr. Reddick said, the 6-week number, that's just a random number. We want to be watching our moms for the entire year. And so that's how I'm going to start. So what did I learn from talking with the Taylors? Baby boy did great, by the way. Be available, be helpful, be reassuring. So it's 6:30 in the evening. I don't know them. They're not my patient. But I have a friend who tells me that their family member needs help. So when you get that call, which I know you do, it's almost never convenient to be helpful, right? But when you think about the outcome and the fact that there are 2 people involved here, mom and baby and dad, 3 people, it makes sense to do that. So one of the things that happened with her, she was getting an induction of labor and things were just not progressing well. She had had a previous surgery and they decided to proceed with a C-section. So when they went to get her ready for the C-section, her epidural was not working. So then the question becomes, well, does she need to get spinal anesthesia? Do they need to do something where just get her numb right away? Do they put her to sleep? Do they redo the epidural? Now, if you have a woman who's in pain and anxious, it's their first baby, do you think that she can make that decision under distress? Very hard. So at 2 o'clock in the morning, I'm getting a text. This is what anesthesia is saying. What do you think we should do? So I ended with the baby boot camp because I really think that one of the things, and I'm throwing the idea out there for whoever wants to catch it, how about we go through with our moms what may happen? If this happens and the epidural doesn't work, then this is what your options are. And these are the questions to ask. But I felt, and even as an OB-GYN, how could we have prepared her for the unexpected, which is what we're talking about today, which is that her form of anesthesia is not working, we have to change course. And so I think a baby boot camp, that's my term that I'm using, you can steal it, where we kind of go through algorithms for our family. If this happens, then this is what we do. If this changes, then this is what we do. And as you know, if anyone in here is on labor and delivery, in a split second, you can go from okay to not okay. And so everything that we're doing about today is really to just expand your thought process for how do we anticipate? How do we plan? What do we do differently? So with that, the maternal alert circle, and I told you the story about that. And I have no disclosures. I think that slide may have gotten skipped, so forgive me for that. I do have a couple of objectives that we'll go over. I'm not going to spend time reading this. We're going to get through most of everything. But I really would love that you would walk away with the interest in reviewing the presentation with all the details. But just what things have we not thought about that can help us better prepare to take care of our moms and babies? So I'm going to start with something that's really close to home for us. Does everyone remember Hurricane Helene? Yes, okay, I say her name with 2 L's for emphasis, okay? Because she really, really did a bad thing for us and other states too. And I have a little bit of hurricane PTSD. I'm from Jamaica originally, and in 1988 we had Hurricane Gilbert. It was my first year of high school, and we had no electricity for a month. And so whenever there's a hurricane, I pretty much don't sleep. So I was up watching the radar, and 40 miles south of Macon, Helene went that way and just did a number on Augusta. And so I want you, when we start thinking about the unexpected, we're in a period now of extreme heat, which is a whole thing for pregnancy. but the chance of us having hurricane or tornado can pop out of anywhere. And what do we want to do for our pregnant moms? We need to start thinking about what happens if that happens in the middle of the night, which could easily happen. The weather is changing. They're predicting 15 storms, hurricanes for this year, which is the most ever. And so anyone in here that's interacting with a pregnant woman, they should have a plan. Where would you go? What would you do? If they're taking medication, do they have a supply packed and ready to go? Is there a bag? Kind of what we do with our moms, right? Around 35 weeks, you tell them have a bag packed by the door in case they have to go in for evaluation or preterm labor. But emergency preparedness and disaster preparedness needs to be a part of our conversation, and it needs to be very intentional. So I have, the link will be on here for the CDC guidance. They go through some really important things that I would recommend. And I love this quote. This actually quote used to be on a billboard on Mercer University Drive, and it says, if you could plan a wedding, you can plan for a disaster. Now, you know how detailed we get with our wedding planning, right? And so we want to be able to anticipate it. I know you can't plan for everything, but you should have a plan. If you are pregnant and you are taking medication or you have any kind of special accommodations, there should be some kind of plan already, and we're responsible for talking to our patients about that. So please, sometime throughout this year, think about that. You know, our hurricane season goes all the way till almost November, so we've got a long time. So the next time it pops up and you see a hurricane, think about all the pregnant women that you know and make sure that they're talking to their providers about having a plan. So the kit, as I mentioned before, 7 to 10 day supply of medications. That's really important, especially if they're hypertensive, diabetic. There are other conditions that would be important. We talked about aspirin earlier. That bottle needs to be in that bag. There are prenatal vitamins. And just as a quick tip, I have a lot of patients who are not always fond of prenatal vitamins. The really fancy ones look like horse pills and they taste like horse pills. So the trick is, everybody can use Flintstones. I'm going to give you a secret. Now, kids usually take 2 Flintstones. A pregnant mom can take 3. So if she's having trouble with compliance, just have her take Flintstones. And if she has a younger child, she can appoint her younger child to be the vitamin police. She will never miss another prenatal vitamin, okay? Copy of medical records, that's really important, having access to information if there's anything special. The whole idea of a routine pregnancy is almost a misnomer. Almost everybody has something, so they should have a copy of that information with them. The Red Cross actually recommends that people download information on a thumb drive and keep it with them, and that way they have access to that as well. So again, we're trying to think about the unexpected and how do we prepare, how do we get ahead, how do we not have things happen. And think about it, you can have a pregnant woman that could travel somewhere. I mean, she could go to Florida, or she could go to Louisiana and she could get stuck there, right? And have issues because a hurricane shows up and she can't fly out. And so we're thinking not just about where they live, but where they may be traveling to at the time that they have an emergency. So the alert circle, I wanted to kind of use that same concept that I mentioned before with our elephants, and really transfer that to what it means for us in terms of the maternal health delivery system. And I heard this term mentioned before, collaboration, and that is the most important thing. As was mentioned before, taking care of our patients is not the job of one person, and we probably do have more than one captain, as was mentioned. And so what we want to do is think about not only the patient's physical health, but their mental health. And that is the part that really is being more addressed now because we're talking about it more, but really we can't really take care of our moms and our babies and our families if we're not thinking about both of those things. What needs to happen in terms of the alert circle if you're in the hospital setting is how to make sure that becomes automatic. So if there's a code, and I'll tell you a story that happened. I remember I was doing a emergency C-section. I had a young patient, probably 21. She'd had a pelvic fracture and came in preterm labor and seemed to be doing well. And then I guess her pelvis decided it was not going to accommodate a delivery. And so we had to quickly convert to emergency C-section. And so we ended up having to put her to sleep because her anesthesia, her spinal or her epidural was not adequate. So put her to sleep, thin girl, got baby out, no issues, doing fine. So I'm doing what I call my cosmetic repair of her incision. And when your anesthesiologist says a choice word, you know you're in trouble, okay? So I looked over, she had flatlined. And so immediately I start doing chest compressions, and everyone starts running around the room. And so we call the team. The wrong team came. Not the best time for that to happen. The only thing that probably really saved us is that we actually had the anesthesiologist in the room, because those things could happen and not actually in the room. And so he was able to give her medications. I'm doing chest compressions, and everybody's like losing their mind. And I have some of my friends from Phoebe here. I'm not sure if they were in the room when that happened, but I remember one of the nurses saying, and I don't remember saying this, we're not losing any moms or any babies today. And so I'm sharing that with you because we need to make sure that when we activate that command for an emergency, the right team shows up. So we have to plan, and then we have to double check the plan to make sure the right people show up to do what we need. And so with that, I wanted to just throw in one thing, the unexpected, amniotic fluid embolism. Is everyone familiar with that for the most part? And so making sure that we're prepared to respond. I'm using the word respond intentionally. I didn't say prevent, because sometimes we don't know that it's coming. But if it does happen, how do we quickly recognize those things and activate the right team? And that is truly, I know someone mentioned the word multidisciplinary. Anesthesia is on board, the nurses are on board. I mean, there's so many components to that. And so I use this example, and there's a hyperlink for A1 in here, which if you have not looked at their protocol, I would recommend you looking at it. Not just because of the amniotic fluid embolism, but because the things that are outlined, we could probably borrow that algorithm and use it for other things. So really just wanting to start thinking about, and I don't want you to be fearful that every pregnancy could go bad, but any mom that we lose is too many. And so we really do have to have the capacity to respond appropriately. And so it would make sense for us to think about all of those pieces. When it comes to fluid management, for example, or replacement of products, if you're in a rural hospital, and I practice I'm in a rural hospital, you may not have adequate platelets. You may not have FFP. You may not only have 2 units of blood. And if that's the case, how quickly can you get access to blood? Who's going to bring it? What do you do in those circumstances? So being able to play all those parts out is really important, because you can have a protocol, but you take your protocol to rural Georgia, and that accessibility is very different. So what then becomes your backup plan? And as was mentioned before, with our hospitals closing, patients will still show up there. I mean, they don't even have an obstetric floor, but they come in and they're in active labor. And sometimes you don't have time to transfer them to another hospital, or you need to find an ambulance. I've been in that position. Or you want to get a helicopter, but the weather is bad because it's Georgia, right? The weather's unorganized. It could be nice today and it's not tomorrow. And so any number of things could force you into a position where you have to handle what you have. And so in that case, who do you call to help you? And as Dr. Reddick mentioned, I've called her and had to transfer patients to her, making sure that you have access to the right people if you don't have that service in your hospital. So just really wanting to share that if your community and your hospital does not have a protocol for these emergencies, then that needs to be something that is on the planning list, because if it can happen, it will happen. So the way that the model works, and the other term for the alert circle, is the maternal early warning systems. How many people are familiar with that term? Okay, good. A handful. Great. So you have homework. There's a link here that you can read up about that and how you can implement that in your hospital. And what are the things that we're trying to do? We want to identify problems early. Someone mentioned before, do we bury our head in the sand? No, we don't. Just because if someone is bleeding and if you just look away, you're going to hope it stops bleeding. No, you got to do something to stop it. When it comes to bleeding, I think of 3 Ps: pressure, platelets, and prayer. And so you have to do something. You have to be ready to do that. Prompting appropriate and timely intervention. Time is everything. Time is money. And so you really want to be able to access things quickly. Let me give you an example of how that can change very easily. A lot of patients that are coming in postpartum may be preeclamptic. They come in through the ER, and so they're going to be the first line. They may have been in the waiting room for 2 to 4 hours, right? And then you're getting the call that we have someone that's potentially preeclamptic. You go down to assess the patient. If they need, you do your exam and they're hyperreflexic, that's a sign of CNS irritability, and you're worried about them having a seizure from preeclampsia. You don't need to, I've done this before, run upstairs to labor and delivery to get a bag of MAG just so you can start the infusion. We had that happen in our hospital, and we were able to work with the pharmacy department, our clinical pharmacist. And so the PICS is in the ER. Now when you select that option for preeclampsia, when the drawer opens, you get your MAG, You get your labetalol IV, you get your hydralazine. Everything that you need comes out in one shot. You're not having one nurse running here and one nurse running there. And so, you want to have accessibility. And so that ability to decrease the time that you're spending and doing little pieces makes a difference for the life of that patient, the life of that mom. And so in your respective communities and practices, what things can we do to be more efficient? And the really nice things sometimes, being in a rural hospital sometimes there's an advantage because it's just less levels to go through. So we had that happen like on a Saturday when I was there. By Tuesday, that Pyxis was updated. We had everything that we needed in one shot. And so just think about how you can really expedite access to what we need. Ensuring clear communication coordination for procedures. So when an emergency happens in the OR, for example, just like how we do a timeout before we do a C-section, there needs to be someone keeping time, someone making a list, someone documenting. The person that's doing the documentation cannot have any other task. There needs to be a record of what happens, because in the event that you need to do a transfer, you need to be able to communicate how many doses of methogen that was given. We do that for postpartum hemorrhage, or if they're doing blood, or if they've checked the pulse ox. Whatever you're doing needs to be documented, and so making sure that you have a person assigned. Now, granted, if you're in a rural hospital, you may only have one labor and delivery nurse, so you got to call Med-Surg and borrow somebody to help you. Or if there is a house supervisor, you got to get them involved. So again, that's a conversation that needs to happen in the hospital setting. So I do understand that the expectations may be a lot. So depending on where you are, one person may be serving more than one role, and that's okay. They just need to know what that role is to get them moving. So I want to tell you a little story. So as was mentioned before, the person that spoke before with Operation Miss. So Catherine Sylvester and I met 3 years ago at this conference, and I texted her today. I was like, "You're not coming?" I was like, "It's our anniversary." And so, but I want to tell you about a case that happened. So I spoke at this conference, maybe it was 2 years. So during the question and answer, she said, "Well, what if you have a patient that keeps going to the hospital and they keep sending her home and her blood pressure's high?" And I was like, "Well, in my smart self, she needs to find another doctor." And so during the break, like we just had, she came and shared with me that she had a patient that she was monitoring who had those parameters and had elevated blood pressure. And I have the link on here. WAB is doing a phenomenal series about rural health and maternal health across her state. And if you haven't looked at the series, you can check this one out. But actually a story was done about her. And so she's a 36-year-old G3P1. She's had 3 pregnancies, 1 live birth. She did have 1 baby that passed from SIDS. She has Blue Cross Blue Shield. And I'm saying that on purpose because the issues that we have don't happen only with patients that have Medicare, Medicaid. It's not just with patients that have no insurance. Patients that have what I call good insurance still fall into that category of needing assistance. And so she had delivered in Savannah, and I have pictures for you in a second, but briefly, she's having elevated blood pressures, had been to the ER twice, and had been turned away, was having a headache, was symptomatic, was terrified, had a baby at home, and had a C-section. And she's also diabetic. And so when Catherine approached me, she said, "Well, we got to find a doctor to see her." Okay, so I'm going to skip over here. How many people know where Clio, Georgia is? That's why I have the map. This is great, right? So she was living in Clio, Georgia. I hope I'm saying it right, because in Georgia we say things all kind of ways. So I don't know if it's like some other word, but for me it's Clio. I'm Jamaican, you can forgive me. So it's 51 minutes to Savannah. So she's high risk. She's been going to Savannah, and she had gone to the ER twice already. And the day that Catherine approached me about her, she went to the ER a 3rd time that night when we were here on that Thursday. So in the break, I called a friend of mine, Dr. Kavanaugh Chandler. He is the CEO for Coastal Community Healthcare Systems. And I said, "I need a doctor who is close to Clio, Georgia." He's in the Savannah, Dublin area, so I figured, random call, he might be able to help me. So he did have a friend who's a family physician who's in Sylvania, Georgia. Do y'all know where Sylvania is? Okay, good. So, and it was actually 34 minutes from where she lived. And so Catherine and I talked on Thursday, and remember, this is a patient that she's monitoring, not my patient, but she's brought it to me. So what do? I could just say, "Oh, she needs to go find a doctor, go back to the ER." Any mom that someone calls you about is a mom that you need to help. And so I texted her on Friday morning. Her office closes at 12 on Friday. She agreed to see the patient at 11 a.m. on Friday. Patient's husband's a truck driver, so she had to wait for him to get home so he could take her to the doctor. She saw the patient, put her on the appropriate medicine, usually going to do labetalol or nifedipine, depending on what's going on, sometimes hydralazine, then arranged for her follow-up and arranged for her to have a cardioechogram. So, alert circle. Catherine knows what's going on in terms of her monitoring. Patient has been to the hospital and has been discharged. So, providers, we need to do a better job of how we recognize and make the appropriate alerts. But the point is that mom and baby were taken care of because of that circle. We had an emergency and the right things needed to happen. And so if you get approached about a patient and you don't know them or you don't live in the area, that's why you got to make friends, right? So you can call people. So I have lots of phone numbers for lots of people in my phone. And if I don't know something, I can find someone who can help that mom. And so we will do whatever we need to do. If we have to go to the moon and come back, we just need to call. Who's it that has the spaceship? Who's it? Yeah, he's getting married this weekend. Everybody's married. Yeah. Wait, so, yeah, Venice is really mad about the wedding. But anyhow, but whatever we have to do, we need to put our resources together to help our moms. So identifying the appropriate people that are going to be in that alert circle. You kind of already know who they are, right? All the players. It's not just who the players are, but how the players work together. So of course, we got to get our moms involved. Moms have to learn how to advocate for themselves, which is exactly what that mom did. She realized that the care that she received was not adequate. Even though it was at a healthcare institution, she had to keep looking. And so I tell my patients all the time, if you don't get the right answer, you keep looking, because that's what I do. And so we need to empower our moms and their families to do the same thing. The partner and the spouse, that was mentioned today, and I think the talk that's following me will be talking about the paternal component. And I had a professor, I spoke at a conference at Morehouse recently, and one of my professors got up and asked the questions about, we're talking about maternal health, but we're only talking to the moms. Why aren't we talking to the other part of the DNA, the other 50%? Because we can't get baby without the dad, right? So really, our efforts really need to be inclusive of everybody who's related. And the person that's usually the partner spends the most time, usually, with that mom. If their feet are swollen, they probably will see it before anybody else does and can bring it to someone else's attention. And as was mentioned in the case before, when who was it? Was it you that spoke? Who was it that spoke from Operation Mist? Yeah, so you know how she called your husband? Because sometimes that's what you have to do, right? you gotta get the husband involved. And so thinking about the partner and the spouse, the healthcare team, everybody pretty much thinks about that team, but the one thing that I appreciated earlier was the involving the pharmacist in the conversation. Very key. I had a case recently, I had a mom that I saw, and I love doing preconception counseling. So she came to me, had 3 babies, history of seizure disorders, on Keppra, wanting to have a baby. I took her IUD out. So I get a chance to say, you gotta be on prenatal vitamins, but what else is important? They gotta be on extra folic acid, 5 milligrams. So I sent the prescription. Patient emails me, Dr. Callins, the pharmacy wants to talk to you. I said, okay. So I called and he said, do you want 5? I said, yes, sir, I want 5. Communication, right? And it may not be something that he sees very often, but I was able to say, hey, if patients are on Keppra or they're on a medicine for seizures, they need extra folic acid so we can prevent neural tube defects. He was like, high five, got it. Patient got her medicine. And so our ability to communicate, and I mean, that was a rural pharmacist, and that's probably why I got the call. If it's Walgreens, I don't know, hopefully I'm not offending anybody, but with just so much going on that you have to have someone that has the time to do that. A lot of our Walgreens have closed, my Walgreens is closed, and so they don't have enough pharmacists. And so sometimes the communication or the gaps in our communication are not happening because people don't care, it's just that their capacity is limited. Right? And so that's where communicating with your patient is important. I tell my patients, if you can't get a medicine because you can't afford it, or they're telling you something crazy, call me and let me know. Then I can make the call, or I can have my nurse to make the call. We've got to figure out how to close the gaps because they exist because there are real challenges in our community, and I wanted to recognize that. Family and friends. So I think that at every baby shower, we should have a discussion about preeclampsia. At every gender reveal, right? Because everybody shows up. And so what better time to educate the village than to do that? It's not uncommon, and for my Phoebe friends, when we have someone deliver, everybody shows up at the hospital. The gardener, the electrician, I mean, everybody shows up. So what if we did a little handout to every person that came by to check on the mom, right? And say, hey, if these things happen, this is what needs to. So we're not using all of our opportunities because of all the people that are caring for that mom and that baby. And we need to really just be more inclusive and more intentional about how we help people jump in that alert circle mode as much as possible. Support groups, community resources, a lot of you here represent those organizations, doulas, and lactation networks. I really want to focus on that because anyone that is going to be in close contact with mom and anyone doing home visits, they're gonna see those things. One of the problems I think with the way our health care system has been working is out of hospital means out of mind. The first 5 days after mom delivers are the most critical. Preeclampsia does not only happen before moms deliver. And a lot of people, because the word says pre, think that they can't get preeclampsia after they deliver. Now, you all know that is not true. That's when we see most of our preeclampsia. Preeclampsia just means pre-eclampsia, which is when they actually have the seizures. So preeclampsia is the warning sign to let you know we need to get mom taken care of before she starts seizing, and that can be bad for mom and for baby. And so just really think about how we utilize all the people that are interacting with our moms. The other part about that is, and I love this idea that was brought up before regarding how do we integrate with our pediatricians. And so there are other states where there's a dual model, and I've said it for years. When mom has a baby, the baby has to go in for, and my kids are 16 and 20, so it's been a minute, but 2 months, 4 months, 6 months, there's like a whole platform. What if our maternal appointments mimic that same schedule? We would catch some things that are taking our moms out if at the 6-month visit, mom is suddenly behaving differently. But we also have to be open to that idea, but we also have to build for that analysis and that combined care. So from the policy level, we still have some work to do to really use those opportunities. And I call those bird in hand moments. Every mom is gonna take their baby in to see the pediatrician within 2 to 5 days. So that blood pressure check that was mentioned before is an easy thing to do. Even if the mom brought the blood pressure cuff they should have in their purse to the office and took it there, and the pediatrician could then call and say, hey, the patient's here and this is what's going on, that would be reasonable. So the tools that we need, we have them. We don't need more money. We may need more people. We don't need more things, although there are a lot of changes now that are compromising that. Regardless, we will persist. But we just have to start thinking about how do we use the opportunities that we do have to form that circle. We have the people, we just have to start being intentional about the process. And then others, depending on the circumstances. I know someone mentioned if we're having an infection needing wound care assistance, that's something that's important. And when it comes to our moms, there are a lot of things that are going on with people that we have no clue about. And so when I interact with families, I try not to be judgmental. I try not to assume. There's a reason that people are making the decisions. My public health degree is in health behavior. If someone is not taking their medicine, there is a reason. Our job is to figure out what the reason is. I had an 18-year-old, crazy blood pressure, first pregnancy. One doctor Monday came back, second doctor, I saw her on a Friday. I was a third physician, and I said, I'm not gonna change this medicine. I'm putting her in the hospital. Admitted her overnight to see what I could do. And then I went to see her Saturday morning. I've never forgotten this. I remember sitting on the side of the bed, her best friend was in the room, and her best friend said, you know, she can't swallow pills. So she'd been getting medicine that was being deemed as not effective, but it was effective because it was not going down her throat. So I put a clonidine patch on her, and she went home on Sunday. Blood pressure was fine. So we are responsible for figuring out why people do what they do. It may not make sense. I had a mom who brought her 16-year-old to see me, who wanted her to be pregnant because she was not well and she wanted to see a grandchild before she passed away. Now, that's not wrong for her to think about her legacy, but me fussing at her 16-year-old for her behavior is not the right way to do that. okay? So I'm sharing that with you because I am always humble, as we all are, when we can just take the time to understand why people do what they do. And then we can work through those things. And sometimes they're hard things. I mean, honestly, some things we wish we did not know. But if we do know, we take the time to dive in and mine, then we can work on that. So determining the appropriate time when to activate the signals, anytime concerns appear. So mom has foot swelling. So usually if I see someone that's pregnant, I look at their belly and then look at their ankles. I'm always looking for swelling. Because it could be that they just have normal edema dependent edema from being up on their feet. But blood clots do happen in pregnant women. And some women have coagulopathies or difficulties with their blood clotting, and they may not know that till they're pregnant. And so just being trained about thinking about when you see a suspicion, if they do have swelling, especially if it's only on one leg, they need a Doppler study. Even if they're not necessarily complaining of pain, if it's persistent and is not resolving the next morning, that's something to think about. Persistent abnormal parameters. So blood pressure, their systolic or the top number may be fine, but the diastolic keeps being higher. So you see it the first time, okay, they had Lay's potato chips last night. Okay, we'll watch it. But if you still keep seeing things and it's not making sense, we have to evaluate them. And that evaluation may not always be convenient. So utilizing our telehealth access, using our health departments, using our federally qualified health centers, all of those networks that are in place is an opportunity for us to get things to patients who may not be in the area where they can easily access that information. And let's not forget about our first responders. Our fire stations, they all have blood pressure cuffs. So if you do have a mom that's having an issue and she can't get somewhere to get a blood pressure and she doesn't have a cuff at home, she can go to her local fire station. She can even call them. If you've got a flat tire, they'll come out and they'll help you, right? And so just really thinking about how we get our moms to what they need. Then clinical suspicion, powerful tool. We call it gut feeling. You see a patient, they don't look right. And it's interesting how even if you've never met a patient before, you can tell something is just not right. And it's okay for you to be wrong. If you think there's something you need to evaluate, there's nothing there, that's fine. But if you have a clinical suspicion, how do you activate the right person? And that goes especially to the people who are in the home or community health workers or doulas who are around the patient, especially postpartum. If you see something and you're not sure, having that communication with their prenatal provider or postpartum provider is really important. So clinical scenarios, and I'm not going to spend too much time here, you all are probably familiar, the cardiopulmonary issues, looking at trouble breathing, shortness of breath. Now, as you know, for anyone that's been pregnant, the bigger your tummy gets, the harder it is to breathe. It's pushing up on your diaphragm. But when does that become concerning? And that's why having a kit at home that looks at your pulse oximeter can help you determine if that shortness of breath is just a physical issue or is there something systemic that's going on with mom. Neurological changes. Bell's palsy happens with our moms. That can happen in pregnancy and can be very debilitating, right? But how do you know if that's not signs of a stroke? I've had people come in and they're slurring their speech, or a family member looks at them and see their face is drooping. They need to be evaluated. So how do we look at that? Hemorrhage, I know that's something that's talked about a lot. And that hemorrhage, even though it happens usually in the hospital after delivery, that can still happen further out too. I had a friend recently whose daughter, again, the phone call, her daughter's in Germany and was supposed to have a follow-up appointment her 6th week on Thursday, but she started bleeding really heavy on Tuesday. So the text message I got was, does she need to go to the ER? Her appointment is in the morning. She's having a lot of bleeding. So, of course, I asked the questions. Is she dizzy? Is she short of breath? Is she soaking more than a pad an hour? When did it start? How many days has it been? So my suspicion was that it was a period, but since she had not had one for 6 weeks or 8 weeks, it was going to be heavier. And so I kind of told her, we can watch it. If these things happen, go to the ER tonight. If not, follow up in the morning. So she went, and they did suspect it was a regular period. But again, what I'm finding is a lot of patients have these questions. Who do they ask? In the middle of the night. How do we get those things answered? I've got another friend right now who is a high-risk pregnancy, and they have, she has a cerclagen, which is great because we lost the first baby. But she said to me, well, how do I know if I peed on myself and my water broke? That's a legitimate question. And if we are wanting or allowing our patients to only use the TikTok, with the THE, for their source of information, we're gonna have a problem with that, right? And so having that bidirectional exchange, which is why those programs that allow for us to be in communication with our moms, and they have access to a nurse line where they can call, or they can call labor and delivery triage to ask those questions, is really important. Again, that alert circle. If mom has a concern or we're worried about something, how do we get the right people in place? And we dare not discredit or not pay attention to something that's presented. I had a patient who came in and she was probably about 24 weeks, thought she was constipated. Her mom gave her what? Who can guess? Castor oil. So she comes in to triage and I do a pelvic exam and what do I feel? Feet. She had a breech, footling breech, double footling breech, and she was in preterm labor. And so that was an emergency C-section. I put an next one on her arm. She was 15. So my point is, when things happen, how do we get our patients to feel comfortable not self-diagnosing and making sure we get the right information? Because her mama really did. She had pressure in the vaginal area, so that would be normal for you to be constipated in pregnancy, but she was actually in preterm labor and they did not know. Okay? And so when we think about the statistics for how things happen and why things happen, some of it is just how quickly can people access the right information to help guide them. So that would have been a call that said, hey, come in, let's check you out, not let's self-treat with castor oil, okay? I'm anti-castor oil if you can't tell. So hypertensive disorders, infection, sepsis, and then other signs, nausea, vomiting, the baby not moving. You know, baby should move at least 6 times an hour. If they don't move, you drink some juice. I know we talked about juice earlier, but just for this one time. And if they don't respond to the glucose, then they want to come in. And then, of course, thoughts of hurting the baby. That's a question we have to be asking everyone. I ask my patients, do you think you're going to throw the baby out the window? So before I ask that question, I usually will say, do you feel like hurting your partner? And they should say yes. And that's how I know they're telling the truth. So when I ask the question about the baby, if they answer me correctly, then if they answer the first question correctly, I know they're telling me the truth. And so you have to really kind of work through that, because sometimes people tell you what you want to hear. And so if you ask the right question, the prep question first, and then you get the truth on that, then you know the second question, you're probably going to get the right answer. So having said that. So where do these, what are the circumstances for the alert circle? Where does that happen? We talked about in hospital settings, high-risk pregnancies, which we do have quite a few of those now for lots of different reasons, but then also limited resource settings. And so I want to really just, for people that are coming from our rural communities, things absolutely look different. And so how do we think creatively about being able to offer patients the same quality of care? Because we know that your health care should not be determined by your zip code. So just because you don't have it in your county, I work in Twiggs County, just because I don't have it there doesn't mean I can't help my patient get to what they need, and that's our responsibility. So we talked about in-person being ideal, but also virtual settings is important. Using telehealth is a very important component. Now we can FaceTime. If you don't have this app downloaded, Doximity is something you can use. You can put your office number in there, so when you call the patient, it looks like the office calling. There's a FaceTime option on there. You can look at the patient, so you can utilize that. It's a free app. I started using it during the pandemic. Convenient locations. We have to start thinking about how we go to where our patients are. Where do our patients hang out? Not hang out, but where are they? They're at church. They're at Kroger, Publix, Ingles, Piggly Wiggly. They're at the nail salon. They're getting their hair done. So we need to be where the patients are. We need to intersect with them. They're in the pickup line at school, picking up their elementary child. So when they're waiting in the pickup line, what better time to walk up to the window and say, hey, have you done X, Y, and Z? So really just thinking about how we're transforming our outreach to be where people are. The other place that's really important is our sports fields, our recreational centers, right? Everybody from the family shows up for the game. Now, we should probably intercept them from going to the food counter, because that's a whole nother thing, although I do like my cheese fries. But just think about like all the other places where we can really interact with our patients. And then, of course, we talked about online. So I'm speeding up. Ooh, I got to go. All right, so lots of information here. Just looking at the things that we want to think about, diverse and inclusive groups. We'll talk about that some more in a minute. Looking at the experience of our different professionals. Focusing on confidentiality and respect, that's really important. Patients have to trust you to tell you the truth. And most of your patients are the people you interact with. Some will look like you, some will not, but you still have to connect with them. And so that has to happen usually very quickly and in a trusted fashion. The website that I mentioned at the beginning, the CDC Disaster Preparedness, they have this chart that's listed there. I've seen this chart in lots of other places too, but your patients should have this on their phone. Everybody in their family should know what those warning signs are. So that way, if they have a headache that's persistent, doesn't go with Tylenol. If they have anything else that's concerning, that's another opportunity as well. Monitoring, we talked about with Operation MIST, continuous monitoring, escalation process if something abnormal is going on. At Liberty Regional, we have a Mom's Hearts Matters program, and if there's an elevated blood pressure, there's an escalation that goes to the nurse, and the nurse calls the physician, and we can either adjust medicine or we can have them come into the hospital. How does that work? Timeliness, as I mentioned, time is money. Patient education, and then regular drills and simulations for your community is also very important. So health equity is of course important. I just talked about the zip code differential. And the fortunate thing for me being in a federally qualified health center, I'm with community healthcare systems, is we see patients across the spectrum. I have patients with no insurance, federal insurance, private insurance, which is great. We see everybody. But we want to make sure that the care that we're giving does not depend on who we're talking to. I tell my students all the time, and I've had a couple of the observed students with me, you take care of your patients like the family you love. I used to say family, but we don't like everyone in our family. So you pick the family that you love. Why is it important to have that maternal alert circle? We want to improve patient safety. We want to enhance caregiver support. The reason I think that our dads are not as involved, we have not taught them how to step up, okay? Now, you know, with guys, no offense, if you want bread, you cannot say, I need wheat bread. You have to say, I need wheat bread in the white bag with the blue stripes with the red star. The more specific we are, the more likely we are to get what we ask for, okay? So similarly, as we are working on engaging our partners, we really have to move towards giving specific instructions and then specific next steps. And you know how women are. We are very stubborn. And so they need to know what to do if their partner is not responding appropriately. You got to figure out that back door, okay? Facilitating care coordination, that's key. We talk about collaboration. And when you do interact with your patients, say you get their phone number, you need to get someone else's phone number in the family, and you need to know where they work, and you need to have that information too. So I ask them, oh, where do you work? Subway? Okay, cool. They think I'm just being friendly, but I document. So if they don't answer my call, I will call the Subway and I will ask for them. And I have been known to show up at people's job before. So yeah, I do that too. Or send the police to get them if they don't respond. I've done it too. I had a patient who had an ectopic pregnancy and she didn't come back in 48 hours. That's a crisis. So the police went and got her and she came. She did not do that again. So do what you have to do, okay? You want people to be independent. You want them to be able to make good decisions. I need information to do that. So a couple of things just for us as reminders. We all know the core things, compassion, but actually especially compassion for each other and the work that we're doing. It is hard to do things with limited resources. And if you weren't limited before, you are probably limited now. But our care cannot change, right? We still have mamas that need to be saved and babies that need to be saved. Our attitude, how we interact with people, resiliency is also very important in the empathy. So I'm going to speed through this. 10 seconds per slide, blind spots. What things have we not thought about to help us with our alert circles? What are we missing? What are we not considering? Preconception care, how women step into their pregnancy. That question was asked earlier, beautiful question. Being able to help people optimize their health. The problem is most of our women will not have access to health care until they are pregnant. Unfortunate. It's almost as if you're not valid if you don't have anything in your uterus. Not very cool. However, we do have resources through our health department, through our federally qualified health centers. Every woman should see a provider at least once a year. Just like it said at the end of the Barbie movie, I did an amen when she said she was going to a gynecologist. But we really have to figure out how to get people access to care. And a lot of our younger patients, because they are young, may think they're completely fine. But we won't know there's a problem until it's too late. The other thing with preconception care is people are taking medications for hypertension or, they have lupus or they may have something else going on, seizure disorders. They may get pregnant and they stop their medication because they're worried. And so that means if they're seeing a primary care provider, before that prescription is prescribed, the question needs to be, what is your plan for fertility? Because that may affect what things they're prescribed. Because what we don't want is a mom who's on mental health meds to stop her medication because she thinks it's going to harm the baby, when we know we got to keep mom alive so she can take care of her baby. And the beautiful thing now with a lot of medications, we used to have a lot more restrictions. For example, even on lithium for breastfeeding. If that's the best thing for mom, she can take her lithium and she can breastfeed if that's what needs to happen. So we've gotten more supportive of supporting that dyad. of merely making sure that we help mom be healthy so she can take care of her baby. So blind spots, so just always think, what am I missing? What am I not thinking about? Bridges. When it comes to trust, I tell people all the time, we build bridges and sometimes we're repairing bridges. That part is very key because sometimes the patients come to you with a baggage from a previous negative experience. So they may behave a certain way towards you. So it's our job to repair that trust. We have to rebuild the bridge. Our fathers, families, friends, frontline facilitators, faith leaders, very important. People, when you think about it, pastors and church leaders are very akin to healthcare. They're like always on call. Someone dies, they're in the hospital, something happens, they're usually visiting that family. So that person will also be as effective in terms of our ability to engage with people in the community. How you lead is very important, and so I have a couple of terms here, and I want to tell you that because you care, you're a natural leader, and you should lead with your heart. So being collaborative, being inclusive, being empathetic, and also using trust. Last pitch I'm going to make, we're in perilous times. There's no way to think about that differently. So the best weapon that we have is to stick together. We're better together, we're stronger together. So if you need to get you some glue so you can remember that, I want you to do that. But everybody that's in here is a resource. We don't have to be best friends for us to work together, for us to get things done for our patients, right? And so I don't want you to be disheartened because the world is falling apart. It is. But when we are together, we can withstand just about anything. And so I don't want to leave this podium without encouraging you because it was hard before and it's even harder now. But if we have to care more, then that's just what we'll do so we can take care of our moms and babies. I've got a bunch of resources here. Some were mentioned earlier. They're all hyperlinks on here. There's the report from the Healthy Mothers, Healthy Baby for 2025 is out. If you haven't looked at it, please take a look at that. The March of Dimes report from last year. There's also the Maternal Vulnerability Index. If you can type in your actual zip code, your county, and it can tell you the numbers and things going on specifically for your area. The Hear Her campaign was mentioned before. The Georgia Perinatal Quality Collaborative have lots of resources. They're connected to our AIM bundles. The Georgia chapter for postpartum support international, they do lots of things regarding postpartum depression. They have focus groups and therapy groups and just lots of options for people that have had pregnancy loss and lots of different things. And so I want you to know these things so you can share it with as many people as you know. And everything that I know, you should know. Everything that you know, I should know. Because my patients should not only benefit because they're my patient. We should be able to share all of those resources. And again, remember, when a crisis happens, and our topic, what's the theme for the conference today? Okay. And I do have a prop, my little elephant here. So when a crisis happens, we have to step up and we have to step in place and we stay there until things are better. And so everybody in here, you are all elephants, do not be offended. And so I'm closing with my quote, you may not be able to change the world, but you can change the world every person with whom you interact. That's important because sometimes the problem seems so big and you feel like you're not making an impact. So zoom in, take care of the person that's in front of you. And that's the reason I became an OB-GYN. Was gonna be a pediatrician, but the babies, they won't tell you what's wrong, they just holler at you. And then the crazy parents, which I'm a crazy parent. So when you take care of a mom, when moms dazzle, everybody shines, right? If they're okay mentally, they do what they do best. If mom eats a salad, everybody eats a salad. The people at work, the people at church, the people down the street. If we focus on the moms, they will do what they do best. And when a mom delivers, they're not thinking about their ankle swelling. They're not thinking about their headache. They're trying to make sure their baby has food. And so because they're focused on baby, everybody who's interacting with that mom, whether it's the bus driver or it's the nail lady or whatever, the nail technician or the esthetician, whatever it is, they should be paying attention to mom. And so all the things, the warning signs that we're talking about, you should be able to walk up to the store and say, hey, what's the warning sign for preeclampsia? They should be able to tell you. That's not exclusive information for the healthcare community. That's really for everyone to be able to know. So step up, adopt the maternal alert circle, just like our little elephants. And I want you to stay in place until your mamas are where they need to be. And if you don't have what you need, find somebody who can help them. Every mom that we save is a life saved. Thank you. So I think I'm supposed to open up for questions, comments, confessions, all the above. Yes. Hey, friend, how are you?
It's fine. I had a quick question. I'm sure we're inside or something out for myself. And I am a physical therapist by trade. But to listen at all the symptoms that you were talking about, I had every last one of them. And after pregnancy, had to go back to the Mercer room. Now, being in healthcare, I should have known, but I didn't. And I am so glad that you are having this conference today. And I want to thank you because I took notes. So now I know what to do with the women that I deal with.
Mm-hmm.
Thank you.
Thank you.
Thank you.
And Ms. Burnside is a super rock star. You can look up Phenomenal Women's Health. She does a lot of engagement with young ladies in the community. And last year, she actually gave me an award. Let me tell you what she did to me. So she called my office and got my number and told me she was trying to help women and what do I recommend? And I gave her this litany of resources. And then she told me she was actually interviewing me and I got the Phenomenal Woman of the Year award, but I didn't realize she was interviewing me. I was just doing my usual sharing of information. So she got me on that. Go ahead.
It's great to meet you, Dr. Callins. My name is Chanel Stryker. I'm the co-founder and executive director of the Georgia Community Doula Coalition. And I took lots of notes similar to Ms. Cheryl. And I really appreciate you taking the opportunity to present this in the way that you did to show the importance of collaborative care and how we all have to work together. As I was listening to everything you were saying, I was taking notes when you were talking about reinforcement for medical providers and staff, about educating families about the benefits and risks of procedures that need to be done, and alternative outcomes. I was listening to you talk about emergency and disaster preparedness and how it's important to know what you need to do in those times and preparing moms for pregnancy in that way. The vitamin alternatives, when you were talking about documentation in the hospital, and it was just so, it just like came to me that doulas are the holder or the facilitators of that circle. All of the different avenues or areas and practices of maternal health that you spoke about, doulas are like significantly resourced in knowing where all of those things are in their communities. And we provide that support and that education to our clients. I was listening to like things you were charging providers with doing, and I'm like, those are things that doulas can help to do, right? And so as the person who stands on the soapbox of like integrating doulas into the maternal health system and a part of the birthing team, thank you so much again for that and for what it sounds like being open to that support and that collaboration and having doulas to be a part of the team to help with those, bridging those gaps and building those bridges. When you were like, the phone numbers, we need to make sure we have all the doulas always have all of the family's phone numbers. We create these systems where we educate the entire family. We sit and have birth planning sessions, postpartum sessions, how to identify warning signs. Just wanted to share that and say thank you for all the information you provided.
And thank you for that. And that means it's happening. So we just have to make sure those connections happen. And there's still, I will tell you, real quick confession, I still see a good number of women who have no prenatal care. Some of them are immigrants, and of course, they're not seeking care because of reasons related to that. But there are some women who have maybe 4 kids and they don't think they need prenatal care. And there's some women who have tried to initiate their pregnancy Medicaid and there's a delay for some sort. And so I'm going to put another charge out there is how do we get to everybody? Those women are in our community. They're going to Piggly Wiggly. They're going to Publix. And so how do we touch those people? But I should not see in 2025, we should not see someone who's had no prenatal care. And so we got to do better about that. And so I want us to extend our arms even further. But we should not see that. We should not be surprised. When I was a resident, I had a woman come in and we thought we had one baby, and then I went to deliver the placenta. I was a trainee, and I said, man, that does not feel like a placenta. It was another head. So she was having twins, no prenatal care. So we just really have to make sure that we are reaching our moms. And if someone is pregnant, whatever the circumstance, sometimes it's planned, sometimes it's unplanned. 50% of them are unplanned for lots of reasons, and that's life. But how do we step into that place?
I just wanted to make a comment on yours regarding like the delay in insurance and things like that coming from a mental health side. I don't know how many people in this room know, but Georgia Medicaid and family planning Medicaid do not cover mental health services for pregnant women.
Now, I need to research that because I thought with our extension that was covered. Is that not true?
That's right, Dr. Callins, that
Yes.
it does cover.
So,
I know that there were some changes coming.
right.
Right now, like my primary client base are your care source, Georgia Medicaid, and we do not get.
So we need to have a conversation to figure out how we make that link. And that's a good point because it's happening also with our lactation services in terms of coverage. And then, of course, doulas were working on that. And so, again, Margaret, we can follow up on that, and we just need to get your name. And so that way, everything that we have if you don't know that and it exists, it's our job to tell each other. So thank you for sharing that.
My name is Eva Martin, and I've been an OB-GYN for almost 45 years, which time flies.
When you're having fun.
Solo practice, been in the VA, now in public health. I just want to tell you about a program that we've been doing now for 10 years through Hudson County Health Department.
Okay.
And the hospital approached us to be able to lower the rates of primarily undocumented patients that came with no prenatal care, potentially higher circumstances, and it was expensive for them as an organization. So thanks to our nurse exec and the staff that I work with Pete and Cindy, and all the staff at Hudson County, we offer our health care to undocumented patients under a contract that they pay for at very inexpensive rates, pay cash. Our no-show rate is about 2%. And we have very good data in terms of morbidity and mortality. We cover the patients up until 36 weeks. And then one of the private practices
We'll take over.
helps deliver those patients.
Okay.
And our data was good enough that Harvard Public School of Health came and said, what are you guys doing that makes a difference? This is a reproducible circumstance. You know, there's a lot of semi-retired OB-GYNs who still want to practice, but don't necessarily want to deal with, you know, the end product that can certainly diminish the morbidity and mortality. And so I would encourage somehow, because it's reproducible across the United States, whether it be for undocumented patients, whether it be for individuals who can't access care, which may be more prominent as time goes on. It's all doable with little pieces of the population. So thank you.
Thank you for sharing that. I'm actually going to get your contact information. So Georgia Watch, I want you to Google Georgia Watch. They have a maternal health component, and they're looking at just that. When I work in Hinesville, there's a pocket of patients from Glenville, Georgia. And the most unfortunate case I had recently, a woman came in and she was preeclamptic and probably 38 weeks, and the baby was gone. She had had a headache for a week, non-English speaking, and did not come in enough time. And when she walked in, we did that heartbeat, it was gone. So I had to deliver a 7-pound baby with no heartbeat. So that stuff still happens. And so I would love to talk to you more about that, but thank you for sharing. I think we have one last comment. I see I'm getting the eye from over here.
I'm Mike Burnside, shows counterpart.
Hey!
So what I want to say is, for the ladies in the house, women in the house, make that man go to that pre-birthing class. I was forced to go. I learned how to push and pull, except when when Cheryl was delivering. I figured she had it by then, I just watched the ball game.
Thank you so much. Thank you for sharing. Thank you for the work that you do. Thank you for giving me your time and attention today. And remember, you're an elephant.